You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 15, 2023. Our topic is contact dermatitis and patch testing, presented by Dr. Luz Fonacier. She is a professor of medicine at NYU Long Island School of Medicine. She is also the section head and program director of Allergy and Immunology. She is also a previous president of the American College of Allergy, Asthma, and Immunology. Right now, you're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 15, 2023. Our topic is going to be over contact dermatitis and patch testing. Our speaker is Dr. Luz Fonacier. She is a professor of medicine at NYU Long Island School of Medicine. She is the section head of allergy, the program director of allergy and immunology, and she is also a prior president of the American College of Allergy, Asthma, and Immunology. Thank you for joining us today. We appreciate it.
Thank you. Can you hear me well?
Yes, I can hear you.
Okay, great. So this talk is really geared to trained fellows as well as those who are starting to do patch testing. We have seen increasing number of our referrals and consultation in our allergy, immunology, inpatient and outpatient on allergic skin diseases. And one of the main differential diagnoses is obviously contact dermatitis. These are my disclosures, none of which will affect our lecture today. So our learning objectives is we want to discuss the various presentations of allergic contact dermatitis as against irritant contact dermatitis, and of course the role of patch testing and the practical aspects of emerging and important allergens. So we know that the diagnosis of contact dermatitis is really based on location, and location. This is the last publication of the North American Contact Dermatitis Group, probably the biggest group that gathers information about contact dermatitis and patch testing. And you will see these 5 top regions are the same almost year in, year out, with just different places in between. So hand is still very common. And of course, your head and neck, which is your face, lips, and eyelid, and a scattered generalized dermatitis as well. So let me start with this case. This is a 52-year-old nurse who came to me probably about 5 years ago. And it looked like I thought she had contact dermatitis. She definitely had hand dermatitis, and you will see the distribution here. And I did a patch test, and the patch test was negative. So again, we went back to what is she doing, and she was actually she started doing this when everything became electronic. And so the final diagnosis with her, and it's been reported in literature, is actually an irritant contact dermatitis. So there are differences between irritant and allergic contact dermatitis, especially of the hands. It becomes very difficult to actually give that diagnosis without doing a patch test. So in more or less, for an irritant contact dermatitis, there are lesions often in the webs of the fingers, only because that's where most of the wetness will pool. It can extend into dorsal and ventral aspects of the hand, and that's you see on the right hand side of what we would call the apron pattern. And it's less responsive to topical corticosteroid. It can precede allergic contact dermatitis, so you can have, and it's not uncommon to have both irritant and allergic contact dermatitis. And as I said, it's a diagnosis of exclusion. You have to exclude allergic contact dermatitis by doing your patch test. The allergic contact dermatitis vesicles are common manifestation of an allergic contact dermatitis. They will favor the fingertips, the nail folds, and the dorsum of the hand because most contacts are more frequent on the dorsum, and the ventral aspect also has thicker skin in the palms, so less prone for allergic contact dermatitis. When we did patch testing to hand dermatitis, the most common relevant positive patch tests are your metals, nickel and potassium dichromate. So nickel and chromium and cobalt is one of them. Rubber components, obviously from gloves, and p-phenylenediamine. So when you see an allergic contact dermatitis, you got to go back and see what the patient's occupation or what the patient's doing. So this is a surgeon who uses gloves, and this is what you see in patients who have rubber pads when they have it in the keyboard. And of course, chefs can tend to have this. And our patient here with a negative patch test, we actually diagnosed as an irritant contact dermatitis. But all of them have locations that could suggest what the allergens are. But most of your patients may not have these locations, and therefore you need your patch test. Moving on to the next most common is the face. So when you have eyelid alone, your allergic contact dermatitis is up to 72% if you only have eyelid dermatitis. Thus, for over 90% of our eyelid dermatitis, we would do a patch test. When you have upper and lower lid extending beyond the orbit, you are most likely going to have allergic contact dermatitis. A very common differential is your atopic dermatitis. We see a lot of atopic children, especially, and you can see that there is worse lesions on the centered on the medial canthus. I think probably it's because the more of the itching and the scratching is in that area, and only less than 10% would be atopic dermatitis if it's eyelid alone, because atopic dermatitis would certainly involve other areas as well. And interestingly, there are some patients you have an irritant contact dermatitis limited only to the upper eyelid. And often you can have something centered on the fold. So if you have an upper eyelid alone, think of an irritant contact dermatitis. Common allergens in allergic contact dermatitis are fragrances, gold because of transfer, and nickel because of transfer as well. Of course, the fragrance is because of the personal products that the patient tends to use. Eyelid plus. So now you're seeing, now we are seeing lips. Lips, generally it can be so severe, but if you have both upper, top, and bottom lips, equal both sides affected, you think of allergic contact dermatitis, most likely to lanolin, propolis, fragrances, including balsam of Peru, and fragrance mix, and flavorings, of course, in cosmetics and lip balms. Gum will have some flavorings as well, and nickel. But if you only have it in the lower lip, or predominantly in the lower lip, or one side over the other, as you can see in this lower slide, think of mouth products, especially toothpaste. And what do toothpastes have? They have cocoamidopropylbetaine, they have propylene glycol, spearmint, and menthol. And these are culprits of allergic contact dermatitis. Incidence of allergic contact dermatitis of the lips is about 25%. Again, patch testing will help you. But the most common cause of lip dermatitis is actually irritant, close to 40%. And you can see why lip licking has become a very common cause, especially in young children. You can pick this up during the office visit of the child where they can't stop lip licking. Another distribution, which we thought was uncommon, but it's actually common, and it becomes a big differential diagnosis for us, especially in atopic dermatitis, is a scattered generalized dermatitis. Two common causes are textile dye and formaldehyde resin, and I'll go over textile dye with you. The primary sensitization of textile dye is occupational. So you have hairdressers where they're exposed to p-phenylenediamine in hair dyes, and they have this day in and day out. And this will cross-react with this dispersed dyes, which accounts for 2/3 of textile dye allergic contact dermatitis. if you are only doing the true test. The true test will test for p-phenylenediamine and only disperse blue as a textile dye mix. So there is a cross-reactivity. About 38% of p-phenylenediamine will also be positive to at least one textile dye that is used as testing that could be missed if you did not use textile dye mix. There's what can you do patch testing to the pieces of clothing? Probably you can certainly do it. Probably you will have a very high false negative. The reason for this is that there's a different usage. You have the sweating, you have the constant rubbing and irritation of the textile on top of the allergen. And you can see here location of textile dermatitis. You can see that the vault of the axilla tends to be spared. Why? Because your clothing really don't go that far, and you will see that the periphery is mostly involved. Now, this is a patient who came to us on the right side with generalized dermatitis, and this was noted after the whole hospital had changed the uniforms. And the primary sensitization, the primary allergen here would be formaldehyde resin, and primarily the sensitization is occupational. Again, formaldehyde in healthcare workers, embalmers, cabinet makers. Now, this is very common. Formaldehyde resin is very common in highly finished garments. When you have wrinkle-free, permanent press, reduced wrinkling, increased strength of your uniform, especially water-resistant lab coats, zip-up greens, even furniture and custom upholstery, you can have exposure to formaldehyde resin enough to cause this dermatitis. Most of the dermatitis from formaldehyde resin is really subacute to chronic. It tends not to be acute. It doesn't occur. I use this uniform for the first time and I'm itching all over. It actually is you've been using this uniform for a while and you have this subacute and chronic dermatitis. The problem with formaldehyde resin-induced dermatitis is even after you have avoided it, there is a very slow resolution, and as much as 50% may not resolve completely. So how do you make a diagnosis of allergic contact dermatitis? Well, obviously, patch testing. And the greatest abuse of patch testing is really failure to use this test. Actually, if the diagnosis of allergic contact dermatitis, if you make only by history, you will undersuspect, underdiagnose, or even misdiagnose them compared to those who actually get patch tested. And the relief of symptoms would be months sooner if you tested the patient as against those patients whom you did not patch tested, meaning you picked up the relevant allergen and you told patient to avoid them. So the top most, and this is the most recent data, I think, that was published last year, the top 15 most frequent positive allergens. You have two metals, nickel and cobalt. You have two antibiotics, neomycin and bacitracin. You have fragrances, which is very important. You will see this as fragrance mix 1, 2, balsam of Peru, hydroxylinolol, and fragrance mix 1. And I highlighted to you fragrance mix 2 and hydroperoxide of linolol, which will not be found on the true test. You have to have extended series to do that. There are 4 preservatives, which include MI, MCI-MI, benzyl isothiazolinone, and formaldehyde. Again, of this, MI alone and benzyl isothiazolinone are not found in your true test. So these are what you're going to miss. And your p-phenylenediamine and propolis. So these are the top 15 positive patch tests. And so what can you patch test? We discussed a little bit about the true test, which has 35 allergens and 1 control. That's why you have a total of 36. And then you have your expanded patch test series. It's the North American Standard Series and the American Contact Dermatitis Core Allergen Series. And then you have special groups. You have a hairdresser, shoes, plants, vehicles, metals. There are different groups of specific allergen exposure. One thing we always add, especially for cosmetics or face, head and neck dermatitis, are patients' products. And then you can also obtain from cosmetic and some other industry-specific allergens that you may not have on your panel. So let's look, what's the difference between your true test, 36 panels as against North American Standard Series, the antigens in the top North American Standard Series, not in your true test, would be your methyl isothiazolinone, which is your MI, fragrance mix 2, benzoisozolinone, and your hydroxyperoxide linalool, that's a fragrance as well. Now, allergens in the true test, not in the North American Standard Series, you have thimerosal gold and quinolone mix. The relevance of these three allergens is a little bit put into question. Thimerosal is an old allergen. Sensitization probably occurs in childhood when we were being given vaccines with mercury. Currently, 99% of vaccines don't have mercury anymore. So the North American Standard Series had removed thimerosal because the relevance is very low. Gold, obviously, you see a lot of false positives with gold. Again, does it have to be in a standard series or not is a question. Relevance of gold is a bit questionable. And the quinoline mix is also a bit questionable in terms of relevance. There are also individual components which are tested in the true test, such as the cane mix, where in the North American standard series, we test individually, such as benzocaine and dubocane. So what's the hypothetical detection rate of true tests against the North American Standard Series? Anywhere from 69 to 75%. What does this suggest to you? It suggests to you that you will probably miss 25 to 30% of positive allergens that you would have picked up if you did the standard, the expanded series, as you did true test alone. And the true test has a higher false negative to neomycin, theorem, balsam of Peru, fragrance, gold, and lanolin. So I think true test is a good way of doing a screening on patients you suspect to have a contact dermatitis. But if it doesn't give you relevant positive allergens, you might consider doing an expanded series. In children, the recommend you can probably just get these from the handout because you do not have enough area in children to do expanded series in the back. You can do the primary and secondary allergens. The true test is approved for children 6 and above. So if you want to go ahead with the true test, again, you might miss a few things, but it is approved for children 6 and above. When do you read your patch test? So most true allergic reactions occur between 72 and 96 hours. There are allergens that will pick early. Your theorem and carbon mix, they are from rubber, and your balsam of Peru is a fragrance. They can pick between 48 and 72 and 96 hours. There are allergens that will disappear after 5 days. And the reason why I'm giving this to you because there are some practices that will ask the patient to remove their own patch test and have the patient come on the 5th or the 6th day, thinking that the patient will save 1 day of coming in for the reading. But this is what you will miss if you do that. And there are delayed patch test reactions after 5 days, specifically metals, topical antibiotics, topical corticosteroids. If that's what you suspect, it is imperative that you do use your 5 to 7 day read and the p-phenyldiamine. Patch test interpretation. So the most difficult to interpret is your marginal reaction. Marginal reaction, these are +1, plus minus. These are palpable. You can feel it. They're just not erythema. Erythema is not considered positive. So it may be allergic if at 48 hours you have this, and then at 72 to 96 hours, you can have an increasing reaction. That's the importance of your third reading at 72 to 96 hours. You have acceleration and deceleration of your patch test read. There are common causes of irritant reactions or marginal reactions, and these are including formaldehyde, fragrances, and potassium dichromate. You can do a use test certainly to confirm the test. Okay, how will you characterize your reactions? Irritant reactions. The first and second are obviously irritant reactions. They have pustules, they have scaling, they have some petechiae, and they have shiny skin, especially the first two, and the cigarette paper appearance. The last one is a very common irritant reaction to metals. What you see are almost little papules, follicular lesions actually seen in follicles around the hair follicles. You can have expected discoloration. Your peak phenylenediamine will be dark brown or black. Your dispersed dyes will be pigmented. These are not palpable. You can try to palpate them and then you will feel nothing. Close your eyes, palpate it, and you will see that there is nothing elevated. But you have the allergic morphology. They can have erythema, but they will need to have infiltration and edema, usually filling up the whole application site. If it's the whole application site, I tend to call it a 2+ reaction. If it's about 1/2 to 2/3 of the application site, I will consider it as a 1+ reaction. You can have papules, vesicles, and bullae, which becomes 3+ reactions. False positive reactions, I showed you this pustular patch test type of reaction, common in atopics, common in metals such as nickel, copper, arsenic, and mercuric, and there's minimal pruritus in this. Cobalt also have a false positive reaction. We call it cobalt poral reaction. You can have punctate erythema. It's almost petechial if you see in your second slide, and it's probably a toxic effect of cobalt on the sweat duct. These are all false positive reactions, so they are negative. You have to determine the relevance of your patch test. Definite relevance is your positive to actually suspected product. Probable relevance is you have a positive patch test and you look at the patient's products and they were there, but you did not test the products. And possible is most likely it's such a common allergen that it will be contained in any suspected material that the patient's using. Past relevance, you're no longer exposed to the positive allergen. A classic example of this is thimerosal. They were exposed in childhood vaccines, but they're not exposed to them anymore. But look at this. The current relevance is definite, probable, and possible. And it's up to you to determine on follow-up where the patient fits in. There is called a SPIN or significance prevalence index number. There are allergens where it's positive. If you have a positive patch test, most likely it is a relevant allergen. And look, the top two are MCI and MCI-MI, methyl isothiazolinone and your MCI-MI. It's a very high relevance. If you're positive to that, you most likely are truly relevant positive. And then you have your nickel, and 4 and 5 are 4, 5, and 6. They're actually fragrances. They have very high relevance as well. 7 is formaldehyde. 8 is propylene glycol, one of the vehicles that we use. P-phenylenediamine is a dye, and then your lanolin alcohol have high top 10 prevalence. Let's talk about the individual allergens. So methyl isothiazolinone, or MI, is a very common preservative. You will see here in your liquid hand soap, very common in cosmetics, toiletries, household products, washing detergents, laundry detergents. It is a preservative, and you will see shampoos, conditioners, baby soaps, and detergents very high on that. And it comes a trade name as Katon, CG, MCI, MI mix. at a 3 to 1. In other words, 3 parts of MCI to 1 part of MI. So you will see that MCI-MI mix, which is part of your true test, will have a 3 to 1, meaning you can see how you can miss MI alone. And about MI mixes will miss about 40% of allergy to MI because of the low concentration in the mix. Our practice will do both MCI-MI and MI alone. Fragrances, I'm just giving you the 3 most common fragrances. And if you only do fragrance mix 1 and fragrance and balsam of Peru, which is found in the true test, you'll pick up about 60 to 70% of ACD to fragrances. So you will see that you will mix 30%, 30 to 40% of fragrances if you just did the true test, and that will include your fragrance mix 2 and your other fragrances that are now out in the market. The fragrance mix, the patch test has a low specificity and a high irritancy, so you can have a irritant reaction. If you can see here on top is a 48 hours, but that's why you need, again, a 72-hour read. You will increase the probability that this is a relevant fragrance mix patch test if the reaction increases in 72 to 96 hours, it increases strength, or you become positive to one of its ingredients. So you look at this, on 72 hours became positive to cinnamic alcohol and cinnamic aldehyde, which we know is part of the fragrance mix 1 that we discussed earlier. So now you're not only being positive to the mix, you're also being positive to individual components of the mix. We move on to p-phenylenediamine. Again, high relevance. It's very high sensitizing allergen. Hair dye is the most common route of sensitization. Usually sensitization starts when men and women start to get into their 40s, start to have their gray hair, and start using hair dyes. Unfortunately, now we have these black henna tattoos, which are used in weddings and in older children and adolescent, and now we have this route of sensitization, and you can see here in reaction, contact dermatitis reaction to tattoos. We talked about p-phenylenediamine and azo dyes, and you will see that in the textile dyes, dispersed dyes account for 2/3 of textile dyes, and there is cross-reactivity to p-phenylenediamine. So actually 38% of contact allergy to PPD found in hair dyes will also have a contact allergy to one of the dispersed dyes. And about 20 to 30% of patients sensitized to textile dyes will also have a positive to p-phenylenediamine. So there is really an extensive cross-reaction between these two. Let's look at systemic dermatitis or generalized dermatitis, and there is such a syndrome called systemic contact dermatitis. You have a contact sensitized individual. Let's say contact sensitized to your topical corticosteroids. And then this same molecule is given orally by inhalation, transcutaneous, intravenous, or some other route, and you develop a generalized or even localized dermatitis. And you call this systemic contact dermatitis. This usually appears within hours to 2 days after the systemic exposure to the allergen. It's rarely associated with systemic symptoms. It does not cause anaphylaxis, but it can cause systemic dermatitis. Now, patch test should be positive, as the cutaneous sensitization has occurred as part of its definition. The clinical manifestation is varied. Usually, it could be generalized, such as this baboon syndrome you can see on the right side, a recall reaction where you have a previously positive patch test that become positive again, or a previous dyshidrotic eczema, as you can see here in the hand You can have a reactivation of your flexular dermatitis, or you can have generalized erythema or erythroderma that you can see here on the left side. So different manifestations of systemic contact dermatitis, same pathophysiology, contact sensitized, you got the allergen in some other route, and you developed a generalized dermatitis. What are the most common causes? And two most common causes are nickel and balsam of Peru. So in nickel, they tend to manifest as vesicular hand eczema reactivation. In mercury, they tend to present as the baboon syndrome, which is flexural and gluteal. In plants, herbals, compositae, balsam of Peru, they tend to have a flare of previous site of exposure, perioral or eyelid, because this is the previous site of reaction. Medication. So in nickel, what are the sources of nickel systemically? Well, you have nickel in food, and it's estimated that systemic contact dermatitis following oral nickel in nickel allergic patients, the normal diet has about 0.1% will react to a normal diet, and the normal diet is about 0.3 to 0.6 milligram per day of nickel, milligram per day of nickel. Whereas a high diet, which is about 2.5 milligrams of nickel, about 50% of nickel sensitive patient can develop systemic contact dermatitis. So how do we translate that to food? So you had a 2-pound lobster, 2 cups of soy, 1 cup of peas, and 2 tablespoons of chocolate. That's 2.5 milligrams of nickel right there. And so 50% of patients who are nickel allergic may flare, may manifest as a systemic contact dermatitis. Balsam of Peru is even more common in many foods, citruses. In children, ketchup is the main issue. So patients, children who I suspect to have balsam of Peru, no ketchups, which is very difficult to avoid actually. Kids, tomatoes contain some balsam of Peru or fragrance, actually cinnamic aldehyde, and spices as well. So there are some cross-reactivity in your natural or organic containing products such as chamomile or echinacea. So again, something to consider, telling the patients to avoid if they have systemic contact dermatitis to balsam of Peru. Note, let me not give you the false idea that everybody who has a balsam of Peru positive patch test is put on a balsam of Peru diet. What we do in our practice is, you have a positive balsam of Peru, we give you a safe list of just contact allergens. Avoid the contact allergens. We try that for 6 to 8 weeks. If there is continuous flare after strict compliance with balsam of Peru free contact allergen, that's the only time that we would consider trying a balsam of Peru restricted diet for about 2 months. And about half of patients with a positive patch test to Meroxicab pereire, which is a balsam of Peru, and avoided balsam of Peru had improvement in their dermatitis. There are other reported systemic contact dermatitis, cobalt in patients who, remember, cobalt is a main component of vitamin B12. I've had patients with recall reaction in the B12 injection after oral ingestion of the vitamin. Aspartame is very relevant to us in the sense that Montelukast chewable actually has aspartame, and systemic contact dermatitis in formaldehyde sensitive patients after aspartame ingestion has been reported. So why? Because aspartame is metabolized into methanol. Methanol is transported to the liver and oxidized to formaldehyde. And methyl-salicylate, which you found in Bengay, pain relief, antiseptics, and patients sensitized to methyl-salicylate may flare when you give them aspirin. In atopic dermatitis, there are certain allergens to be considered, but when do you consider contact allergy in atopic dermatitis, when your dermatitis worsens, when it changes distribution, when it fails to improve or it improves and then immediately rebound. But there are atypical distribution. I would consider patch testing sooner atopic patients who have head predominance, hand and feet, eyelid predominance, and lip or perioral predominance. Treatment-resistant hand eczema, adult or adult onset atopic dermatitis, or severe and widespread dermatitis before initiating systemic immunosuppressants. Topical corticosteroid, we kind of discussed, but I want to highlight because this is something we give all the time to our atopic patients. So overall, between 0.2 to 5% of all dermatitis patients would have a positive topical corticosteroid patch test. And unfortunately, 85% will have multiple topical corticosteroid allergies. So you will suspect that again in those who don't respond to topical corticosteroids or get worse when you apply it or improves then flares. So if you have this population and you patch tested them, you will actually pick about close to 20% of these adults would have a positive topical corticosteroid allergy, and about 25% of these children would have a topical corticosteroid allergy. So you can see here on the left side, this patient with this atopic dermatitis of the face with the flare, we patch tested her and she was positive to triamcinolone. The patient on the right, high risk because of stasis dermatitis, been seeing me for a very long time. Suddenly comes here with exacerbation. Patch test was positive for tixocortrol. So here you can see that there are different steroid classification. Your steroid classification could be based on potency, class 1 to class 7, class 1 being the most potent, or allergenicity. And allergenicity is based on group A to D. You can see that there are cross-reactivity within the group A and within group B, C, D, and D1 and D2. There is some cross-reactivity between D and A, but if looking at the prevalence rate, you will see that group C is the least cause of it. So I have patients where I suspect corticosteroid allergy. I would just put them on group C until I'm able to patch test them. So this would be like your desoxymetazone group. There are issues to patch test them. If you have a very high concentration of corticosteroids, it can suppress your allergic reaction. If it's too low, you don't have enough steroid to elicit. But I mentioned this earlier, extremely important to do late reading. I do at least a day 6 or 7 because you will miss 30% of topical corticosteroids if you did not do late read. On the right side, you can see that I tested for the actual product and it was positive on day 7. But on the left side, if you look at your budesonide 0.1%, what you're seeing here is a rim effect. In corticosteroids, a rim effect is a positive patch test. The reason for that is you have a higher concentration of your anti-inflammatory steroid in the center, but you have less concentration in the rim. So your reaction rate is more on the rim side. This in the delayed reading most likely will become positive. So this in topical corticosteroid is a true positive, but in most other allergens, for example, to fragrances, there's probably an irritant effect. Biomedical device, there's really a dearth of data on this, but it's always a question that comes up when I give lectures, so I decided to put it in. So there are more than 1 million joint replacements a year in the US, and it's estimated it will be 4 million a year by 2030. We do have an aging US population, and this population requests to maintain mobility, and so thus joint replacement. And the reported manifestation of implant allergy includes dermatitis or implant failure. Which subgroups are a higher risk? So We know that sensitization to metal, this is a positive patch test to metal, increased 6.5% after an arthroplasty. For a hip arthroplasty, sensitization to the three common metals, nickel, cobalt, and chromium, is 25% if the joint is well functioning. So just having that joint in, about 25%. If you have a failing joint, it's about 60% would have a positive patch test. With a knee replacement, again, 20% in patients with no implant, 48% if your implant is stable, and close to 60% if your implant is unstable. So there's available evidence that there is a correlation between metal orthopedic implants, development of metal hypersensitivity, and metal loosening, but we really don't know which came first, the chicken or the egg. We know that 10% of joints will fail. The most common cause of joint failure is not allergy. The most common cause is mechanical and infection, and that needs to be ruled out. And contributing factors include obesity, cigarette smoking, and osteoporosis. Allergic causes, metals, nickel, cobalt, and chromium are more common reported, but titanium has rarely been reported. You have bone cements, and you have to test bone cements as well. Your acrylates, hydroquinone, and then you have your liquid component and your powdered component and your HEMA or hydroxymethyl acrylate. So there are two timing in patch testing. Pre-operative, a patient has a history of metal allergy, is going to undergo hip replacement, and he's concerned, you and the patient and the surgeon is concerned because of possible reactions. So there, as I said, is it the metal or is it the acrylates? So the acrylates are, you can get a history from reactions to gel nails or skin glue, Dermaband or Gorilla. And there are also reactions to topical antibiotics, such as bacitracin, neosporin, polymyxin, which can be included in some joints when they're actually replaced. So 70% reported pre-op history of metal allergy are sensitized to allergen. Nickel, cobalt, and chromium are the most common. But the bone cement is rare in this group pre-operatively, okay? This goes up post-operatively. And some studies have shown that patients with a high suspicion of metal allergy who had a pre-operative patch test guided implant selection have improved outcomes. So what if you did a pre-implantation patch test and you had a positive patch test? What as an allergist are you going to do with this information? Okay. There are a few issues. One is which of the implant will give the best outcome. If the implant with the nickel will give you the best outcome, functionality, and durability, that's not for you as an allergist to decide. That's for the surgeon to decide. And the question is, does a positive patch test to metal found in the best device warrant using an inferior device? And your role, really, as an allergist, is to identify the metals with a positive patch test, identify the metals with a negative patch test, and you can give guidance on safe materials. In other words, you can say these are the positive and the negative patch testing. There's a retrospective case control study of prior hip replacement. Patients with a positive patch test and a history of metal hypersensitivity have significantly shorter lifespan of their implants. There is no prospective study, however, for this, and so this is currently in need of more research. Post-implantation even poses more problems. Most of the referrals we got is joint failure, there's loosening and there's pain. In these patients, we have to make sure that infection and biomechanical issues have been ruled out. Dermatitis, mostly above the site of implant. So usually this begins weeks to months after implantation, and they are resistant to medical therapy. Note that 10% of joint replacement will fail. And as I said, these have to be ruled out: infection, biomechanical issue, toxic effects on DVT. And of this, 50% of patients referred after all of these have been ruled out have a positive patch test to some component of the joint replacement. About a quarter to a metal and about 21% to bone cement. Again, increasing evidence to support patch tests as the next step in evaluating patients as a cause of joint failure only after other causes have been ruled out. These are the bone cement components that we test, again, because these are used in the bone cements. And there, is Melissa blood test, lymphocyte proliferation test. We just had a consult yesterday for this. It cost our patient $680. Insurance will not reimburse it. It has 8 to 10 allergens, so you have limited allergens here. There is rapid transport is increasingly important. Why? Because you're looking at live lymphocyte that should transform when they're exposed to the metal. Okay, and so it has to be in FedEx, it has to be in good condition, to otherwise you have false negative results. It's really relevance is very limited. Maybe there was one reference where you have a patients with negative patch test and persistent concern of metal allergy, and these negative patch tested patients had lymphocyte transformation test, and titanium was positive by the blood test, and they had the implant removed and to a non-titanium one, and the dermatitis improved. Again, very limited data at this point. Both the practice parameters, American Contact Dermatitis Series, said there's very limited value, and there's false positive, false negatives, and relevance is unknown at this time. Okay, now you did your patch test in somebody who already have a metal device. So we're talking now post-implantation positive patch test. We already said that this is higher in patients with failed implants. So what do we write when we send our consult to our surgeons? So this is actually the gist of our consult letter. So sensitization to metals are significantly higher in patients with failed than well-functioning or without an implant. Okay. Next thing we say is a positive metal test does not prove causality of symptoms, and you have to make sure that you have ruled out other causes, including infection and biomechanical issues. There is not enough evidence at this time to make overreaching recommendations for symptomatic patients with a positive patch test to metals or bone cement to have that removed. And the decision on implant revision following positive patch test results can only be made after a thorough discussion between the patient, the allergist, the dermatologist, and or the orthopedic surgeon. So hard to make conclusions, but it's good to know what are the positive patch tests. And also, I think more important is a negative patch test tells you that there is no evidence of delayed hypersensitivity going on at this time. So for me, a negative patch test is easier to deal with than a positive patch test. Moving on back to our other allergen patch tests. So now I'm talking about general contact dermatitis, not biomedical device. So you suspect allergic contact dermatitis until your next patch test can be done 2 months from now. What are you going to tell your patient? There is such a thing as a local diet, low contact allergy products. So this is elimination of the most common allergens. We talked about the most common allergens, including fragrances, preservatives, your MCI, lanolin, cocamidopropylbutene, and p-phenyldiamine. So what I did is I just put all of this in my contact allergen avoidance list, and it generated for me certain products that don't have this. So then what do? I give a list of products to the patient that based on what the patient needs. I have here shampoo, conditioner, moisturizer, sunblock, and some makeup for women, and they will stay on the low contact allergen products until I am able to do a patch test. In pediatrics, there has been study on a recommendation on these, where it's estimated that a third of children with allergic contact dermatitis will benefit from a preemptive avoidance strategy. So avoiding these 10 allergens may improve the children prior, again, to patch testing. And if you cannot patch test, they may have to stay on these allergen avoidance products. Okay, other pearls. We're now trying to summarize. In summary, there are allergens when you do your patch test that you can load prior to, but there are allergens that has to be loaded immediately before application of the patch test. That includes acrylates, fragrances, and any allergen in aqueous vehicle. Systemic antihistamine has no effect on patch test. We don't need to discontinue antihistamines, but oral corticosteroids have to be avoided. Usually I have them avoid it for 4 weeks if possible. Delayed patch test readings are common to metals, topical antibiotics, and topical corticosteroids. And delayed is about 7 days read. So you have your 48 hours where you remove it, 72 to 96 hours is your second read, and your third read maybe like 6 to 10 days. Testing for MCI mix, which is alone, will miss about 40% of allergy to MI, methyl isothiazolinone. And always patch if you can. I mean, it's extremely difficult to predict the allergen. And the relief of symptoms averages 143 days sooner if you patch tested them than if you didn't patch test them and the patient tried to guess what the allergen is. Pitfalls of patch testing. You know you can't patch testing patients with acute or severe dermatitis, especially our atopic dermatitis patients have so much dermatitis in the back. Systemic steroids, I said, but topical steroids you want to avoid about 7 days on the area where you will be patch testing, which is the back usually. Fragrances are a mild irritant, so be cautious about weak positive reaction. Postural reactions are false positives, especially in atopics. This includes commonly to metals, copper, nickel, arsenic, and mercury. And once you have a positive patch test, please give patients two things. One, what they're allergic to, and what they're not allergic to, and we call it safe list. There are two programs, the CAMP, Contact Allergen Management Program of American Contact Dermatitis Society, and the CARD program. We tend to use the CAMP program because it's from the ACDS. The only thing is you're required to be a member of that, and you will need an endorsement from a member. And please, I have just send me your CV if you want to join American Contact Dermatitis Society, which then gives you access to Contact Allergen Management Program. It's pretty easy and it helps the patient tremendously. If you go into camp, you write down what you have a positive patch test to, it prints out what the positives are, and then below that it gives you a list of different products that are devoid of these contact allergens. These are coding that you would have on your handouts. These are what we use. Feel free to use them. And these are useful resources. We just published the annals, I think, last year on the more common contact allergens. And then you have the contact dermatitis group. And of course, we have the in practice practice parameters. So thank you very much. And I would love to take questions from you guys.